Finals SAQ87 Congenital Heart Disease. A 5-year-old child presenting for day case dental surgery under GA is found to have a heart murmur that has not been documented previously. A. What features of the history and examination might suggest that the child has significant congenital heart disease? History. History suggestive of cardiac failure, such as failure to thrive, difficulty feeding, recurrent chest infections, cough and poor exercise tolerance. History of squatting, parental report of cyanosis, syndrome known to be associated with congenital heart disease, such as Downs, Vater and Turner's, family history of congenital heart disease. Examination, irregular pulse, cyanosis, signs of cardiac failure, such as tachypnea, accessory muscle use, sweating, cool peripheries, crackles, tachycardia and hepatomegaly. Features of murmur that suggest pathological murmur, such as grade 3 and above, pansystolic, diastolic or continuous murmur, murmur with harsh characteristic with radiation, precordial trill or heave, abnormal second heart sound, click or gallop rhythm. Features suggestive of syndrome associated with congenital cardiac defects. B. If the murmur is caused by an ASD, what ECG finding would you expect? This includes prolonged PR interval, right bundle branch block, left axis deviation if primum defect, right axis deviation if secundum defect. C. What imaging modalities might be used in the assessment of ASD and what specific additional information may be obtained? Echocardiography, transthoracic or transesophageal, to determine whether secundum or primum defect, for assessment of involvement of tricuspid and mitral valves and shunt between ventricles, assessment of direction of shunt, assessment of presence or absence of pulmonary hypertension. Cardiac MRI, for 3D structure of heart lesion, valvular involvement and shunt volume. Cardiac CT, for 3D structure of heart lesion and chamber size. Chest X-ray for assessment of pulmonary edema. D. List the current national guidelines regarding prophylaxis against infective endocarditis in children with congenital heart disease undergoing dental procedures. Be aware of the increased risk of IE in these children. Explain to patients and parents regarding risk of prophylaxis outweighs benefits. Do not give antibiotic prophylaxis. Do not give chlorhexidine mouthwash. Prompt treatment if infection does occur. Comments. 39.1% pass rate. The question was poorly answered by many candidates who could not list the history and examination findings in such a patient. Many felt that congenital heart disease only caused left-sided cardiac abnormalities and were ignorant of national guidelines of infective endocarditis prophylaxis. Causes of congenital heart disease includes unknown cause, genetic defects, teratogens and maternal disease such as rubella and diabetes. Advances in treatment leads to increased survival of patients with congenital heart disease. Hence, there will be increased number of these patients presenting for non-cardiac surgery. Congenital heart disease patients are at risk for multiple long-term sequelae, and they often require lifelong medical surveillance and therapy. In patients with CHD, mortality risk is 5 times higher for major versus minor surgery. Physiological and risk-based framework can be applied to the anesthetic management of a child with CHD presenting for non-cardiac surgery. High-risk red flags for non-cardiac surgery includes single ventricle circulation, parallel circulation, aortic stenosis and cardiomyopathy. Additional Q&A. What is the incidence of congenital heart disease? CHD is the most common congenital defect with incidence of 8 in 1,000 live births. VSD is the most common, 32%, followed by PDA, 12%, pulmonary stenosis, 8%, coarctation of aorta, 6%, ASD, 6%, TOF, 6%, aortic stenosis, 5%, TGA, 5%, HLHS, 3%, and AVSD, 2%. What are some of the unique features of the neonatal heart? The newborn myocardium is not fully mature at birth. Newborn myocardium is poorly organized and has fewer myofibrils with fewer contractile elements. This reduces tension development. Underdeveloped calcium cycling and excitation contraction coupling leads to cytosolic calcium dependence. Incomplete sympathetic innervation combined with intact parasympathetic system provides heightened vagal tone, increasing the risk for bradycardia. Beta-adrenergic receptors are less sensitive and may be downregulated in children with congenital heart disease. Newborn myocardium is less compliant, develops less contractile force, and is less responsive to inotropic support than mature hearts. There is increased cardiac dysfunction in newborns with CHD before and after surgical repair. Myocardial maturation is generally complete by 6 to 12 months of age. What are the 3 shunts of the fetal circulation? The fetal circulation is a parallel circulation that contains 3 shunts that function to provide the most highly oxygenated fetal blood from the placenta to the developing heart and brain. The ductus venosus shunts well-oxygenated, nutrient-rich blood in the umbilical vein from the liver to the right atrium. The blood is then shunted through the foramen ovale to the left side of the heart, ultimately exiting through the aorta. In the presence of atelectatic, amniotic fluid-filled lungs and increased PVR, deoxygenated blood returning to the right ventricle is shunted from the main pulmonary artery through the ductus arteriosus to the descending aorta. It can then flow by a reduced SVR pathway back to the placenta for reoxygenation via the umbilical artery. How are shunt fractions calculated? Using cardiac catheterization data, relative flows in the pulmonary and systemic circulations can be calculated using the fixed principle. QP divided by QS equals SaO2 minus SvO2 divided by SpVO2 minus SpAO2, whereby QP is pulmonary blood flow, QS systemic blood flow, SaO2 systemic arterial oxygen saturation, SvO2 systemic mixed venous oxygen saturation, SpVO2 pulmonary venous oxygen saturation, and SpAO2 pulmonary arterial oxygen saturation. How are the different types of congenital heart disease classified? CHD can be classified in multiple ways, including segmentally, anatomically, and physiologically. Anatomical classification focuses on structural abnormalities. Physiological classification focuses on hemodynamic abnormalities and the clinical consequences created by the lesion. Understanding of physiological categories of CHD allows anesthetists to predict the effects of anesthetic agents and ventilation strategies on systemic and pulmonary blood flow. CHD may be classified into 3 physiological categories. Number 1, normal or series circulation, whereby deoxygenated blood returns to the right side of the heart and travels to the lungs through the pulmonary arteries. This oxygenated blood returns to the left side of the heart and travels via the aorta to the rest of the body. The second type is parallel or balanced circulation. Systemic and pulmonary circulations are not separated. This figure shows a large VSD as an example. Oxygenated and deoxygenated blood completely mix. The amount of pulmonary blood flow and systemic blood flow is determined by the difference between PVR and SVR and obstructive lesions. The QP to QS ratio refers to the ratio of volume of PBF to SPF. A QP to QS ratio of 2 to 1 means that there is twice as much PBF as SPF. Increased QP to QS ratio leads to heart failure, pulmonary congestion, respiratory infections, failure to thrive, and damage to pulmonary arteries. Reduced QP to QS ratio leads to cyanosis. The third physiological type is single ventricle circulation. There is only one functional ventricle, which prevents the child from undergoing a biventricular repair to establish normal series circulation. Patients born with single ventricle physiology have only one functioning ventricle to provide both pulmonary and systemic cardiac output. Single ventricle physiology is a parallel circulation that, if not repaired, will lead to chronic cyanosis and volume overload CHF. By definition, single ventricle physiology exists in any CHD that requires Fontan palliation surgery. Palliative procedures are performed to allow one ventricle to pump blood in series through the aorta to the body, and then the blood flows down a pressure gradient through the lungs via pulmonary arteries and back to the heart. Pulmonary blood flow is dependent on transpulmonary gradient. Regarding palliative surgery for single ventricle congenital heart defect, the ultimate goal of single ventricle repair is to provide a series circulation without intracardiac shunt or obstruction. Additionally, these patients often require intraoperative treatment for myocardial dysfunction and arrhythmias. Anesthetic management of these surgeries is very complex and requires close attention to balancing PVR and SPR for blood flow. Traditionally, this is done in stepwise fashion over the child's first few years of life. There are classically 3 successive surgeries to achieve this goal. Stage 1 palliation is performed in the newborn period and involves securing pulmonary blood flow, often with a modified BT shunt. A small Gore-Tex graft is sewn from the subclavian artery to the right pulmonary artery. In the case of hypoplastic left heart syndrome, a new aorta is also created to stabilize systemic blood flow, also known as Norwood operation. Stage 2 palliation occurs at a few months of life. A cavopulmonary anastomosis is created by taking the SVC off the right atrium and connecting it to the branch of pulmonary artery. This surgery, commonly called modified bidirectional gland operation, begins the process of reducing volume overload on the single ventricle. From this point onward, the patient's pulmonary blood flow is dependent on direct venous flow to the lungs. Stage 3 palliation is performed at approximately 2 years of life. This is the Fontan completion and involves creation of inferior cavopulmonary artery anastomosis. This establishes the series circulation. The single ventricle is now responsible for directly pumping blood to the lungs. Physiologically, specific congenital heart disease can also be classified as acyanotic or cyanotic. Acyanotic CHD can be further classified into those with left-to-right shunt, such as ASD, VSD, and partial anomalous pulmonary venous return, and those without left-to-right shunt, such as coarctation of aorta, aortic valvular disease, and cardiomyopathies. Cyanotic congenital heart disease can be classified into 3 types: those with ductal-dependent pulmonary blood flow, such as Epstein's anomaly, tetralogy of Fallot plus pulmonary atresia and tricuspid atresia; those with ductal-dependent systemic blood flow, such as hypoplastic left heart syndrome, interrupted aortic arch, and critical aortic stenosis; and mixing lesions without ductal-dependent blood flow, such as AVSD, TGA, and double outlet right ventricle. What is meant by ductal dependence when describing cardiac lesions? The ductus arteriosus is a fetal blood vessel that shunts deoxygenated blood from the right ventricle to the descending aorta to return blood to the placenta for reoxygenation. In some forms of CHD, there is complete obstruction of either pulmonary or systemic blood flow. In lesions such as pulmonary atresia or hypoplastic left heart syndrome, a PDA is the only means for supplying pulmonary or systemic blood flow, respectively. However, the ductus arteriosus normally closes in the presence of high PaO2 seen following birth. Therefore, infusion of PGE1 is vital to maintain ductal patency and supporting life until a palliative or correction surgery can be performed. These patients should be managed in specialist centers as they are extremely sensitive to changes in PVR or SVR, myocardial contractility, and preload. Aim to keep physiological parameters as close to what is normal for the patient as far as possible. Patients dependent on a BT shunt to maintain pulmonary perfusion share similar characteristics. What is Eisenmenger syndrome? Irreversible increase in pulmonary vascular resistance occurring in response to chronic high pulmonary blood flow, i.e. any large left-to-right shunt that is untreated, leads to shunt reversal with consequent cyanosis. The degree of shunting depends on PVR to SVR ratio. Increasing SVR or decreasing PVR leads to higher arterial SpO2. Avoid reductions in SVR, such as neuraxial anesthesia, and rises in PVR, such as hypoxia, hypercapnia, and acidosis. Eisenmenger syndrome is associated with high mortality and morbidity. What are the common genetic disorders associated with CHD? This includes Down syndrome, typical cardiac lesion AVSD and VSD, DiGeorge syndrome, associated with aortic arch abnormalities and VSD, Marfan syndrome associated with aortic root dilation and dissection, Apert syndrome associated with PS and VSD, charge association, variety of cardiac lesions possible such as VSD and AVSD, VATER syndrome, which stands for vertebral abnormalities, anaesthesia, tracheoesophageal fistula, and renal abnormalities. This is associated with VSD and TOF. Goldenhar syndrome is associated with VSD and TOF. What are the long-term cardiac complications associated with CHD? Residual shunts, obstructions, heart valve abnormalities, surgical trauma, inflammation, foreign material implants, and myocardial injury can lead to many long-term consequences including ventricular failure, cardiac arrhythmia, heart block requiring pacemaker, pulmonary hypertension, subacute bacterial endocarditis, and chronic cyanosis. What are the long-term non-cardiac complications associated with CHD? This includes renal CKD, for the lung, restrictive lung disease, pulmonary hypertension, and plastic bronchitis, for Fontan patients, GI and liver, congestive hepatopathy, cirrhosis and enteropathy, neurological, cerebrovascular disease, depression and anxiety, hematology, anemia, polycythemia, and thrombosis. Those with the following long-term sequelae of CHD have increased perioperative risk. Number 1, myocardial dysfunction, including heart failure and cardiomyopathy. Number 2, arrhythmia, including permanent pacing. Number 3, cyanosis. And lastly, pulmonary hypertension. What's the prognosis for children with CHD following surgery? As surgical, anesthetic, and post-op care have improved over the last 50 years, survival following surgical intervention has improved to well over 90% at major CHD centers. However, long-term outcomes are still associated with significant morbidity and mortality. Up to 50% of mortality associated with birth defects in infants and children results from CHD. Patients who have had definitive repair of simple lesions such as ASD, VSD, and PDA are unlikely to have long-term sequelae. However, patients who had complex repairs such as valve repair and single ventricle palliation are more likely to have long-term sequelae. Anesthetic management of children with congenital heart disease for non-cardiac surgery. Risk stratification. Risk stratification is complicated due to heterogeneity of cardiac lesions and surgical procedures. 3 factors to consider for risk stratification for patients with CHD for non-cardiac surgery includes assessment of CHD complexity, identification of long-term sequelae and high-risk features, and assessment of surgical risk. Assessment of CHD complexity is via ACS and SQIP pediatric CHD classification. Patients may be classified as minor, major, or severe. Examples for minor defects includes unrepaired asymptomatic acyanotic CHD and repaired CHD with no residual hemodynamic abnormalities requiring no medications. Major lesions includes unrepaired symptomatic acyanotic CHD, repaired CHD with residual hemodynamic abnormalities. Severe lesions includes unrepaired cyanotic heart disease, pulmonary hypertension, ventricular dysfunction requiring medication, and patient listed for heart transplant. Minor lesions are low risk, major lesions are intermediate risk, severe lesions are high risk. Next is identification of long-term sequelae and high-risk features. The following conditions significantly increases the risk of non-cardiac surgery: single ventricle circulation, parallel circulation, aortic stenosis, cardiomyopathy, heart failure, arrhythmias, cyanosis, pulmonary hypertension, age less than 2 years, ASA class 4 or more. When the patient does not have these features, they are classified as low to intermediate risk. Presence of one or more of these features are considered high risk. If time, geography, and local resources allow, patients with high-risk features should be managed at a specialty center that has on-site cardiology and pediatric cardiac anesthesia expertise. Lastly is assessment of surgical risk. Presence of one of the following places surgery in the major category: emergency surgery, intrathoracic surgery, intraperitoneal surgery, vascular reconstructive surgery, orthopedic and neurological procedures with potential for significant blood loss. Major surgical procedures are intermediate to high risk. Preoperative assessment. Key features in pre-op assessment: knowledge of underlying lesion and type of circulation, to assess whether changes in SVR or PVR are likely to be of significance, and the expected oxygen saturations for the type of lesion. Assess for evidence of long-term complications and other features that put children into high-risk category. Assess for respiratory tract infections. Changes in airway reactivity and PVR may be poorly tolerated in children with reduced pulmonary compliance or pulmonary hypertension, especially those with gland or Fontan circulation. Assess drug therapy. Most cardiac medications should be continued before operation. Some anesthetists prefer to omit ACE inhibitors. Cardiac medications are not associated with electrolyte disturbances, so routine pre-op blood testing is usually unnecessary. Aspirin should be continued to prevent shunt thrombosis. Children on warfarin needs monitoring and bridging therapy with IV heparin. Venous access may be problematic and may alter the choice of anesthetic technique. Many children have had multiple peripheral and central venous lines. Sedative pre-medications are commonly used to reduce distress, minimize oxygen consumption, and may reduce the amount of induction agent, therefore minimizing reductions in SVR. Regarding endocarditis prophylaxis, national guidelines must be followed. Turbulent or high velocity blood flow in the heart associated with CHD can cause damage to endocardium and heart valves. Damaged endocardium can be nidus for infection in the presence of bacteremia or septicemia. Bacteremia can occur during dental or surgical procedures, which can lead to bacterial endocarditis. Prophylactic administration of antibiotics during these procedures can prevent the development of endocarditis. However, the overall risk of IE from surgery is still low. Guidelines have not been in agreement about antibiotic prophylaxis in the prevention of IE. European Society of Cardiology and American Heart Association have restricted prophylactic antibiotics to those patients with the highest risk of adverse outcomes. NICE guidelines advise against prophylactic antibiotics altogether, except for patients at risk of IE who are undergoing GI or genitourinary procedure at a site of suspected or proven infection. There are no global consensus for patients traditionally considered high risk. NICE guidelines define high-risk patients as those with previous IE, those with acquired heart valve disease with stenosis or regurgitation, those with heart valve replacement, hypertrophic cardiomyopathy, and structural congenital heart disease, excluding isolated ASD, fully repaired VSD, fully repaired PDA, and closure device that are thought to be endothelialized. In patients at high risk of IE, the decision to provide prophylactic antibiotics for dental treatment should be made by the treating clinician after discussion with the patient. Local protocols should be followed. Administration of antibiotics is not risk-free. Patient at risk for IE can be then treated with amoxicillin, ampicillin, cefazolin, or clindamycin if they have penicillin allergy. Surgical patients should continue to receive prophylactic antibiotic treatment as indicated for their surgical procedure. And in these cases, it is reasonable to choose a medication that will also provide prophylaxis for IE. Preventive measures to reduce the risk of IE includes maintenance of oral hygiene, timely treatment of infection with pathogens that cause endocarditis, antibiotic prophylaxis prior to invasive dental or invasive oral procedures, closure of PDA or VSD. Back to pre-op assessment, history. Antenatal history, explore maternal disease, drug and alcohol intake. Explore birth history, history of prematurity, PDA, birth asphyxia associated with persistent fetal circulation, i.e. persistent pulmonary hypertension of newborn, assess for symptoms such as cyanosis, hypercyanotic spell, failure symptoms, respiratory infection, faints, collapse, chest pain, and poor weight gain. Identify the physiological classification of CHD and perform risk assessment as above. Assess for comorbidities, chromosomal abnormalities associated with CHD. Determine whether the child requires endocarditis prophylaxis and other aspects of history, such as symptoms suggestive of congenital disorder, family history of cardiac disease, symptoms suggestive of acquired heart disease such as infective endocarditis and rheumatic fever. Physical examination, assess vital signs, inspect for dysmorphic features, features of difficult airway, cyanosis, poor weight gain, work of breathing, chest deformity, and JVP. Palpate pulse, suprasternal trill, ventricular heave, apex beat, liver size and dependent edema. Percuss for liver size and ascites. Auscultate for murmurs, such as systolic and diastolic murmurs. Features of innocent murmur includes soft and no trill, systolic and short, asymptomatic, best heard at left sternal edge, no radiation, changes with posture. Review most recent cardiac evaluations such as ECG, chest X-ray, echocardiogram, cardiac catheterization data, and cardiology visit. Pre-op logistic planning includes timing of procedure, location of procedure, recovery plan, and consider transfer to a higher level of care hospital. Assess whether there is time for transfer, especially for urgent and emergency surgeries. For elective surgery, high-risk patients should be transferred to specialty center. For intermediate risk patients, there should be pre-op discussion with a specialty center to determine appropriate location for care. Low-risk patients can likely be managed anywhere. For emergency surgeries, for intermediate and high-risk patients, discussion should occur with specialty center if time allows, and transfer should be discussed. Low-risk patients should be managed where they are. Anaesthetic considerations. Patients with CHD have been safely managed with general anesthesia, neuraxial anesthesia, regional anesthesia with sedation. Available research does not recommend a specific technique or medication. In designing an anesthetic plan, begin with your preferred anesthetic plan for the specific procedure and consider how that plan would affect hemodynamic goals of your patient. Ask whether the patient will be able to maintain appropriate cardiac output and oxygen delivery with that plan. In patients with parallel or balanced circulation, how will the anesthetic plan change the QP to QS ratio? If cardiac output is not sufficient during procedure, what will be the best initial management? Options includes fluid administration, administration of vasoconstrictor, or inotrope. This is a list of some factors affecting PVR and SVR. PVR increases with hypoxia, hypercarbia, acidosis, increased intrathoracic pressure, atelectasis, increased hematocrit, hypothermia, and sympathetic stimulation. PVR reduces with supplemental oxygen administration, hypocarbia, alkalosis, and reduced hematocrit. SVR increases with hypothermia, sympathetic stimulation, and vasoconstrictors. SVR reduces with hypothermia, sepsis, volatile anesthetics, propofol, reduced hematocrit, spinal or epidural anesthesia. Anesthetic agent considerations in CHD. High-dose sevoflurane reduces SVR and contractility. There is less effect on SVR and contractility with low-dose sevoflurane. Hence, avoid prolonged exposure to high-concentration sevoflurane. Expect a slower induction in patients with myocardial dysfunction and or right to left shunt with sevoflurane induction. Propofol reduces SVR markedly. There is reduced contractility and respiratory depression. In patients with shunts, the reduced SVR leads to increased right to left shunt, and in high rapid propofol doses, This may cause shunt reversal in those with left to right shunt. Hence, propofol must be used slowly and carefully in high-risk patients. Ketamine preserves SVR, PVR, and contractility. It increases heart rate. It preserves respiratory drive and has analgesic and anesthetic effects. In patients with significant myocardial dysfunction, a direct myocardial depressant effect from ketamine has been reported. However, ketamine is still widely used in this group of patients. Ketamine is especially useful in patients with right to left shunt. Etomidate preserves SVR, PVR, and contractility. However, it leads to adrenal suppression, which limits its use. Consider etomidate in patients with significant myocardial dysfunction if concerned about the use of ketamine. With the use of opioids, SVR and contractility is usually preserved. There is increased PVR and reduced heart rate and reduced respiratory rate. Opioids are cardiovascularly very stable, even in high doses, but in spontaneously ventilating patients, the use of high doses is limited by respiratory depression. Benzodiazepines are used as an adjuvant to reduce the concentration of inhalation or intravenous anesthetic agents needed to induce and maintain anesthesia. However, use caution in patients with severe myocardial dysfunction due to negative effects on myocardial contractility. There is preservation of contractility and respiratory rate with dexmedetomidine. However, bradycardia, hypotension, and hypertension may occur with its use. Presidex is useful as an adjuvant to reduce concentration of inhalational or IV agents needed to induce or maintain anesthesia. However, use caution in patients with bradycardia or heart block. What are the anesthetic considerations for children with left to right shunts? A left to right shunt will ultimately lead to volume overloading of both ventricles and may result in congestive heart failure. In pediatric patients, congestive heart failure may present as feeding difficulties, failure to thrive, tachycardia, and poor perfusion. Excess blood flow through the shunt via ASD or VSD and through the developing pulmonary vascular bed can lead to increased PVR and pulmonary hypertension. Anesthetic management of these patients includes judicious use of oxygen so not to increase left to right shunt and decrease cardiac output in the face of congestive heart failure. Treatment of congestive heart failure with inotropes such as milrinone, dopamine, or adrenaline. Management of pulmonary hypertension with pulmonary vasodilators such as inhaled nitric oxide. Management of arrhythmias that commonly arise during surgical repair such as complete AV block and junctional ectopic tachycardia. Note that in children with left to right shunt, there will be little to no effect on the speed of either inhalational or IV induction. What are the anesthetic considerations for children with right to left shunts? Right to left shunts occur when there is ASD, VSD, or PDA, and right-sided heart pressures exceed those on the left. These can be caused by elevated pulmonary pressures from pulmonary hypertension, or long-standing left to right shunts resulting in isomangas. Right to left shunt physiology can also occur in CHD with obstruction or restriction to pulmonary blood flow. Anesthetic considerations may include management of pulmonary hypertension, bubble precautions to avoid paradoxical emboli, which can lead to stroke or myocardial ischemia. Children with right to left shunts, speed of inhalational induction will be slower and are more affected by insoluble anesthetics. IV induction may be faster as the anesthetic agents bypass the lungs to reach the brain. What is pulmonary hypertensive crisis and how is it treated? In patients with pulmonary hypertension, the pulmonary vasculature is often hyperreactive to various stimuli that causes pulmonary vasoconstriction, such as hypoxia, acidosis, hypercarbia, hypothermia, and pain. When PVR increases to a point at which right ventricular pressure equals or exceeds left ventricular pressure, pulmonary hypertensive crisis may result. This is potentially lethal, and right ventricular failure may ensue, diminishing pulmonary blood flow, cardiac output, and coronary perfusion. Treatment includes increased PaO2 by increasing FiO2, treating atelectasis and control ventilation, provide alkalosis with hyperventilation and treating metabolic acidosis, control stress response with adequate analgesia and anesthesia, pulmonary vasodilation with nitric oxide and IV prostacyclin, maintain coronary perfusion pressure by maintaining SVR with IV vasopressin, phenylephrine, or adrenaline. What is tetralogy of Fallot and how are TET spells treated? TOF is a tetrad of anatomic findings described by Fallot, including ventricular septal defect, overriding aorta, RVOT obstruction, and right ventricular hypertrophy. Depending on the degree of pulmonary obstruction, these patients can present with normal blood oxygen saturation or hypoxemia. Regarding TET spell or hypercyanotic episode, the RVOT obstruction in TOF can have a dynamic component. The subvalvular RVOT is muscular and contracts in response to inotropic stimuli such as catecholamine release. When such contraction occurs, or if SVR decreases significantly, less blood will flow through the pulmonary artery and desaturated blood will be shunted right to left across the VSD into the left ventricle, reaching the systemic circulation. Subsequent hypoxemia and acidosis increases PVR further and worsens the right to left shunt. This acute hypercyanotic episode can create a downward spiral, ultimately leading to cardiopulmonary collapse. Treatment is increased SVR using vasopressor such as phenylephrine 5 to 10 mics per kg, reduce PVR by increasing FiO2, hyperventilation, sodium bicarbonate, etc. Relax the RVOT with beta blockers and deepening anesthesia. However, avoid too deep of anesthesia which can decrease SVR. Increase stroke volume with IV fluids. Other anesthetic considerations: vascular access may be difficult. Prepare ultrasound and additional providers. In patients with high risk of collapse with induction, consider obtaining IV access prior to induction. Bubble precautions to avoid paradoxical emboli. Clinical problems associated with cyanotic CHD includes polycythemia, increased blood viscosity, coagulopathy, reduced tissue perfusion, and end organ ischemia. In response to chronic hypoxemia, these patients can develop polycythemia when hematocrit exceeds 65%. Increased viscosity of the blood increases the risk of thrombosis, stroke, coagulopathy, and poor blood flow in the microcirculation. Hypoxemia with impaired blood flow leads to tissue ischemia and organ dysfunction. In the heart, ventricular dysfunction occurs as the myocardium is subjected to chronic ischemia and is exacerbated by hypertrophy associated with ventricular outflow obstruction as in pulmonary stenosis. Regarding neuromonitoring and neuroprotective strategies to improve outcomes following cardiac surgery in children, children with CHD undergoing cardiopulmonary bypass are at risk for neurological injury due to risk of thrombosis, low cardiac output, and hemodynamic instability. Near-infrared spectroscopy monitoring, maintaining adequate MAP and cooling the patient, and use of dexmedetomidine have been used to reduce the risk of neurological complication in cardiac surgery. These are my references. Thank you.